We're in Ghent, and Andrea just did his second Z poem. So we've got the first one on video. We're going to keep trying to get them on video and see how we go. So how did feel that went? I'll share the video here.
Well, I think it went well compared to the first one. I think there were some it was more difficult somehow, and later I understood, I think, partially why it was difficult, because the access to the esophageal lumen was very difficult. First I did the gastroscopy and it was pretty straightforward to go in there, but then when I started to cut, it was almost impossible to have access to that part, and also so I struggled a lot to make my cut in the 12 o'clock position, like the final cutting of the mucosa to get into
incision.
The incision, and also later. But I think overall.
Well, let's start with that. Shall we? Let's have a look at it. So first things first, this looks like a relatively decent case, right? Not attempted before, with a nice, relatively meaty septum. Okay. So I didn't see this before. So now I'm looking through it to have a look at what you said about the difficulty, struggling to get on it straight. We make a nice injection. That's quite a nice injection, I would say, in a decent spot. You're right over the septum clearly, because when we go back, I mean, maybe I would have injected more here, but whatever. When you get it coming up, you're quite good with the dynamic, and septum is clearly in the middle of this. So great. And the same here. I mean, that was a good second injection. I think that's really nailed the septum. So okay. But then the incision. Okay. So let's have a look.
Yeah, it was more towards the left. I really struggled
to get to the right.
Yeah, because of the channel, but because of the position mostly, and then we changed something later.
So I think that's nice. I mean, you do 1, 2, 3 to get in the space. Clearly you're in the space, and you can see you are, and then you go for injection. So I think that worked pretty well. And then your directionality. So for me, I want to go this way. So okay, let's see what happens.
Yeah, because maybe the cuff of the anesthesia was too inflated. So
I think in this procedure that can definitely be
an issue. Because this was like, I didn't say anything, but then I struggled.
Yeah.
So I arrived to a certain point, then I struggled a lot.
So you clearly have exposed the septum for those watching here, and so then you want to cut up here, but you were struggling to do that. But let's see how it went. Okay, I see from the time that you're struggling to. Okay, this looks better.
I think 1 or 2 taps, but I wanted to expand it a little bit more. It was not. And then you arrived, I think, more or less here. It started to cut, and then.
Well, I think I'm not here yet, and I think you had already got quite a nice view here. I mean, of what you need to do. So I'm not sure that it was open enough, was it? Because when I came in, I've opened it more down here, but for this side, it's for sure enough access. And then we see some bleeding and difficult, and then I say I want to take over. So okay, and whatever. And then so this is the sort of thing, right? So this is what I was saying to you about the level of spray, I think, and I was saying to you, like, you need to make some impact, because the problem is, like, quite often is the case, right? The scope is putting fluid out, you're having fluid in the plane, and you need to make some impact on it, and you're not going to make some impact on it unless you do something like that. And then you get that where it's this image, right? The difference between this image and the one before, where it's all totally collapsed. That means that you've got space to work. And what I didn't see a lot of this procedure was this. So then I was wanting to see a lot more expansion of this plane, and there's a couple of ways to achieve it. One is position. One is seal with the scope on the mucosal entry, and the third one is water. But water, the problem with water, of course, is that you can't easily cut under it, not with this knife. So you have to then suction the water out, whatever. So we'll get past the bit which I did, which was exposing to the bottom, and I think it's important to know what we're talking about. Actually, I don't think I had completely exposed it, because I think we found later that this was still there, and I could have at this point easily cut this, but didn't. So actually, this is probably where we needed to cut up here and up here, and then expose all this more. But I didn't do that. This was very difficult, and at this point, I think we asked for the tube to be reduced, or had already asked for it at that point. And then there's this part, which I think is there's a couple of interesting things about this. One is the use of water to see what's possible, right? So you see, I mean, compared to without water, where you can see nothing, water definitely helps you. So if you're really struggling to get in somewhere, then using water can help. But in this case, it was quite clear to me that wasn't going to solve the problem. And then we had this part here, which was holding back, and there was a choice to spray it or not. But the problem with spraying this right onto normal mucosa, so I think Endocut was the clear solution to this. And then it was that. Then there's much more space, and then it was relatively quite easy to get in there. There's no prizes for this, apart from just to see the degree of distension, right? So always when I'm doing it, I want to see, I'm using it all the time on the insufflation, like not 1 second I'm not on the insufflation, because I want this level of insufflation so that I can easily give the spray effect. Yeah. So here we have the spray effect going around here a bit like this, and then again and again to expose this. And I probably exposed this quite a lot more than I needed to, right? But does that matter? I don't think so. That really matters. Okay, and then there was the question about what we do about the septotomy. So probably I was too early to that. I probably should have told you, or I should have opened this more, but okay, it is what it is. And it made for some interesting discussion points, I think. So maybe that's not bad. I marked the two sides so that you knew, and I both knew what to do, although I don't do this in routine practice, and I don't suggest that you have to either. You can see the 2 points in the view now. And then we talked about the technique, and you talked about whether we should just sit on here with a knife or whether we should really compress with a knife. I think in the end, you did a very nice job. You asked me how much it should be out. And this is, for me, a very nice amount. Of course, one of the problems with spray is that if you get too much amalgam, as you saw, it stops cutting. So maybe you could have come a bit more superficial here to avoid that. And then you could have then gone back and done it. And maybe that's the thing that I couldn't really say in the procedure. But the directionality was real nice. Then you did the same thing for the other one. Okay. But I think you weren't sure where you were going. So one solution is what we did later, is to put the knife further down here, then torque the endoscope, and then pull back along here. That's one solution. And we did it in a minute, so we can show it. This was a problem, wasn't it? And then I think it just came off with pressure. And then we had this, so we had a bit of bleeding coming from here. We had a blood vessel on the mucosa, and we had this. So what I really want to say about this is that there are some views, right? I'll show you the ones I think, that view, right? If you could maintain that view, I mean, you just go, here, done. Right? But the views that you often add was like this, where I'm not sure if the mucosa is being touched or whether, probably not. But do you know what I mean? So you have to strive, I think, for this view. And you might say, well, David, you are just a freaking perfectionist. And yes, I am a perfectionist. But I think that if you try to achieve what I'm asking you to achieve, you will supercharge your skills. And in the end, you will just sit back and think, okay, well, now I can do what I want to do, right? So I think that's the benefit of it. So what you want to do is try and obtain this view. And then if you have to cut in the middle, it's okay, because you're far enough away from both sides. The problem with this, I see this all the time, is that tissue is all compressed, and therefore you don't really know what you're injuring by doing that. And I also said to you about the plane and onto the muscle, and probably you weren't, but the point is you just don't know because it's too compressed. So what I was trying to get to achieve was this. Of course, water is stopping you cutting, so you couldn't do it. And you did achieve it. But if you see the sorts of views that you were having here, you just didn't have a chance because you couldn't be precise enough, because your view wasn't good enough. And so to get that view better, I suggest push in more. I suggest more insufflation all the time, plus or minus water. But as I said, water can be a problem. And then we had this part. So this was really interesting for me, and I think hopefully you got something. So this was me doing it. The idea was to push the knife, embed it at the point where you want to start cutting, right? Then push this knife in a bit, pull the scope out a bit, push the knife in a bit, pull the scope out a bit, change the angle so that it's now on the zone that you want to go. And you also have your piece of your knife, which is up on the zone where you want to cut, right? So really what is down there is entirely compressed muscle going this way, where you can cut. And then you can just, for me, either turn the small wheel, or I think you had trouble with that, so use torque or whatever you want to do to control it. You did it. I said that I thought that this was too high. Okay, maybe it was the same as mine looking back. I also said that you should push in, and you pushed in quite a bit, so we know what's too much, and then you came back. So this, I think, was good. And then you very nicely did this. I mean, you controlled it, you turned into the same plane. I think this could have been a little bit more up, and you can, with this tip of the triangle, you can drag things, right? So that's another good thing about the triangle knife. You could have dragged it up a bit, maybe, but all right. Everything in the situation is better if the tissue is not compressed, because it cuts better, you get more control, whatever. I don't think this went fine. It went very good. You said to me that here that the wheel, you could not control the wheel, and I said, well, just let the electrosurgery work, because that does happen, and then things fall apart by themselves. And then that was very good. Excellent, in fact. And then we had a nice part about picking the fibers
up. We changed technique here, so not dragging the muscle, but yeah, because it's changed the...
Well, you've got much more view now, don't you?
And
I think you used the very nice. You used the injection to. These was very strangely 3 planes here. Normally, as far as I recognize it, there is this one's joined to this one, and you have a middle plane, and you have this plane. But okay, whatever. Splitting of the esophageal muscle is clearly something that can happen. And then you nicely did this, and then we talked about maybe using cut for the last part. Actually, you can use cut as well. A nice technique is with the triangle, you can use cut face on. It does work. So here you could have just pushed out and cut, rather than spray, because the problem with spray, you see, you're very close to the mucosa. Okay, this was a nice technique of just sitting on it and going, and then here also this pushing traction sort of technique with splitting works very well. So that was very good. We talked about this bleeding quite a bit, about I showed a bleeding here, bleeding on the mucosal side, and I don't know what you think, but I mean, I was never going to, you should never, for me, coagulate this, because if you do, you're in trouble. This maybe we could have, but again, it was very proximate to this, and so my technique in this situation, others may be different, is just to wait a bit. So you saw me wait a bit, you saw me sit and just think about it for maybe like 2 or 3 minutes, and in the end, what we had was something that wasn't bleeding. I mean, this is the view that it's always interesting to see the view where someone makes a decision and accepts something. And I think the view that I had where I accepted it was this. So if we play the video, I mean, I'm not compressing it. It's not really bleeding. It's not really even oozing. So, okay, we leave it. And then this, so I think this is very interesting for you. I don't know what other people have different techniques. I'm sure there are other ways of doing this, but I do think that the goal is to get this onto here and to get the septum to invert into the clip, right? The goal. And if you can do it with suction, fantastic, because you get a nice closure. In this case, you see that I want to lift it up. So here's the incision line, lift it up here, up. And I took it off there purposefully because I thought that it might grab too much. I'm sure there are other ways of doing this, but I do think that the goal is to get this onto here and to get the septum to invert into the clip, right? The goal. And if you can do it with suction, fantastic, because you get a nice closure. In this case, you see that I want to lift it up. So here's the incision line, lift it up here, up. And I took it off there purposefully because I thought that it might grab too much. And now I'm thinking, okay, here's the end of the incision line, so I'm pretty much on it. And I'm always looking for, see, there's a bit of turn here, clip turn here, to get that line totally perpendicular to this line. So this leg and this, the incision, should make a cross, like a proper 180 cross. And that's what I was saying to you about perfect clipping, because it's just logical, isn't it, that if the clip is orientated like that, the leg should be maximally able to sit equally on both sides.
Yeah, of course, that point, your space of maneuvering compared to other procedures like ESD sometimes is quite narrow, but I don't know, what are your comments on this procedure? How can I improve
No, I think
what it is?
I think it's in the details, and I think that I don't know what you think about what I just said, but we spent 20 minutes talking about the fine, precise details, and I think that this is where your learning is. And each time I already saw the difference between 1 and 2. There's a clear change in you've thought about it in between times. You've clearly been to virtual. I would go to more virtual. There is more virtual. Look at it, think about the different types, the different things, and think very carefully again. Review this one. I think that's where it is. The devil is 100% in the detail.